Hello, my name is Professor Brian Oldenburg from the University of Melbourne, and it's my very happy to welcome you to the third GACD Implementation Science Research Training School. It's my real pleasure to welcome you here today, and I could imagine some of you are listening to this lecture early in the morning, some of you are listening during the day, and others of you might be listening very late at night after you've put your children to sleep for the night and so on. But wherever you are in the world and whatever time zone you're listening to this lecture, I warmly welcome you to this third school, and I want to just give you some background to the school before I then give an introductory lecture about the field of implementation science and why it's important and why we're focusing on this in our program. So with GACD, we've been conducting implementation science training workshops and other activities since this initial program, which was conducted in Xi'an in China in 2014. And since that time, we've run many different training programs and workshops. Some of these are indicated on this slide, but there have been many others in many countries and throughout the world. 2 years ago, almost exactly to the day, we undertook the inaugural 5-day research training school in Sao Paulo, Brazil, and we had a wonderful group of trainees and faculty from all around the world for that school. And then again, almost exactly 1 year ago, we conducted the second school in Bangkok and had an even larger number of participants, around 70 participants from every country and region of the world. And then earlier this year, we had already been planning to conduct the third training school, 1-week training school. We were still deciding where to hold this in the world, but of course, 9 months ago, the world was struck by the coronavirus, and the coronavirus has obviously had a huge and terrible impact on all of our countries, some countries more than others. I'm sure many of you have been more personally and directly affected in your own lives and with other family members and people in your networks of friends and work colleagues. So this has been a terrible impact on the world, and also it's had a huge impact on healthcare delivery, which I'm sure many of you have had direct experience of, but it's also had a big impact on how we would deliver a course and a program like this, which we now could not deliver face-to-face as we had planned, and now we've moved to this virtual care delivery mode. And I want to just say a little bit more about that. However, the objectives still remain the same as those objectives we've had for the 2 previous schools. You know, it's for some of you, this course will be very introductory. Others of you have already probably participated, maybe participated even in other GACD workshops. Some of you are already part of GACD funded projects, so you've already had some exposure. So for some of you, this course might be very introductory. Others, you might be coming into it at a more mid-career level, but we're confident that there's going to be something in this school for all of you. You're going to learn a lot more about theories, models, study designs and measurement, and we're going to expose you to practical examples of many of these. We're going to also give examples of how the kind of research we do in implementation science field can be applied to policy and practice to make a difference. We'll also illustrate and demonstrate, I think, by our interactions through the school and with one another, that collaboration and networking globally is key and central to this field. We'll be giving many exemplars and case studies of dissemination and implementation science. And we'll also be talking quite a lot about this field of implementation science in relation to your career development and what you want to do with your future careers to maximise the difference you make in the world and the impact that you have on policy and practice in your own countries, more regionally and globally. The program for the next fortnight, you've already seen the program schedule, and we've explained the fact that you will listen to the lectures like this one before the relevant following plenary sessions, and then that will be followed by small group sessions. And we'll explain all of this in more detail during the first plenary this coming Monday. And as we work through the program, you will also have the opportunity in your small groups to apply many of the learnings and understand how those learnings can really enrich and improve and strengthen your projects, as well as a project that you will all be doing in your own small groups. The plenary sessions will also be an opportunity to meet more of the international faculty and ask questions and to explore many of your own ideas and your thinking and so on. And we've also got some other interesting features that we'll introduce into some of the plenary sessions and breakout rooms and that sort of thing as well. This is the first time that many of us have used this kind of platform, so we're going to do our best to make sure that it works as well as it can possibly work. I also want to recognise the fact that we've got a wonderful international faculty, some of whom have been on our journey for some years and have participated in the first two training schools as well, others who have joined for this program. And we've really worked hard to ensure that the faculty also is representative of your diversity and the regions and parts of the world that you come from as well. And all of the faculty have very rich and impressive academic research credentials, well funded. They know a lot about many of the different research funding schemes from around the world and so on. So you'll have the opportunity to explore and interrogate them about their knowledge and experience. If you look at the far right of this slide, you'll see the column headed facilitators, and you can see three facilitators' names mentioned there: Beryl Maritim, Enying Gong and Katrine Dunhu. And the facilitators will be key and central to the program because they're going to be working with you, and each of you will be in a small group, and they'll be peer supporters and facilitators for the work that you'll be doing in the small groups. And then we have another 7 facilitators as well, and all of these 10 facilitators have participated in previous GACD training programs and schools, so they have their own rich experiences as well. The other important feature of this program is that this week we have gone live with a GACD University of Melbourne Implementation Science eHub, and this eHub is going to support your learning through the 2-week program and hopefully beyond. And once it was clear a few months ago that we would only be able to deliver this program virtually this year, we moved as quickly as possible to get funding support for this hub from GACD and to mobilise it and get it up and running at the moment, you are the first cohort to be using this eHub, so we really want to hear your about your user engagement with the hub, your experience of the hub, and get feedback on how we can improve it in the future. And then early in 2021, we will then make this hub publicly available to the broader GACD research community, as well as anyone in the field of implementation science globally. So there are the pre-recorded lectures and presentations, which I really urge and stress very strongly that you listen to these before the relevant plenary sessions, and it's clear in the program what the sequencing is there. Really reinforce the importance of the small group discussions and interactions. The interactive Q&A, which will happen during the plenary sessions, and some of the other technology we'll be using. Networking and interacting will be fundamentally important across the whole 2 weeks of the program and beyond, because the networking, I think, will be important for you in your future careers and work. And then, as I've just mentioned, we'll be launching, or we have just launched, this new implementation science eHub, which provides all of the e-resources and supports that you'll need for the program. There have been a number of monographs and textbooks written about implementation science. You'll see many of these resources on the eHub, and as well as many other articles and a lot of the literature in the field. This is one, this is one monograph that with some colleagues we collaborated with WHO to write for WHO and their network within countries, the member countries around the world. This is probably one of the best and most well-known textbooks of dissemination implementation research in health, edited by Brownson, Colditz and Proctor. And just in the last couple of years, there's another new edition for this book. There's other textbooks which focus more specifically on implementation change in healthcare. So I'd encourage you to look at some of the textbooks in this field as well. So that's all by way of introduction. Now I'd like to come to the more substantive part of this lecture, and I'm going to spend the rest of this lecture 1A, talking about why implementation science is important. And then the companion lecture, the next lecture, which I want you to listen to, is lecture 1B, which is going to talk about what is implementation science. So I think of implementation science as it's a new research paradigm or a new approach to research for improving clinical and population health. And through the remainder of this lecture and lecture 1B, I'll explain to you why I believe it is a new paradigm and a new way that we can use research and evidence to really improve clinical and population health. So why the need to study implementation? Well, why is this an important thing to do? Well, I think at the sort of most global level, it's important because global health challenges are wicked problems, and they're wicked problems because if we, for example, we look at the causes of chronic diseases, these causes are individual, they're community level, they're local, they're national, they're regional, but they're also global, you know, globalization, urbanization, population aging, etc. And I think we've seen an illustration of that with COVID-19, that while countries can take their own action or local communities can take some action, the action they take at a local level is influenced by what's happening at a national level with directions and policies and infrastructure support, but also what's happening at a global level in terms of coordination. So a characteristic feature of global wicked problems is they can't just be addressed by simple solutions. They have to be multi-level, multi-sectoral, and ultimately solutions which require global cooperation and collaboration. And all of these are wicked challenges and difficult to address in a coordinated, structured and well-resourced way. If we look at this in another way in relation to NCDs at a societal level, this can only be done by multi-level solutions. Secondary and tertiary care are important, as well as sort of individual care at a primary care level as well, coordination, but also context relevant policies as well. So there needs, for any of the health issues or the levels of health issues in the circle on the left, each of those requires multi-level strategies, actions and policies on the right that address each of those features and characteristics as well. I'm pretty sure that all of you will be very familiar with the fact that NCDs already 4 or 5 years ago accounted for almost 3/4 of all deaths, and now it would be over 3/4 of all deaths, and at least half of those deaths occur in people less than 60 years. So in other words, deaths that are preventable to a large degree, and we're not doing a good job of that. But the other important feature of that statistic is that over 80% of those deaths, the mortality, the preventable mortality, occurs in lower middle income countries. And it was the United Nations in 2011, September 2011, 10 years ago, which devoted a whole General Assembly to looking at the global challenge of NCDs and what countries in the world could do to tackle this terrible burden and global threat. And out of the planning work and the strategy development from that initial General Assembly meeting came the targets for global NCDs and a global monitoring framework to evaluate countries and the world's performance towards achieving those targets. And in 2018, there was a UN high-level meeting to review countries' performance towards achieving a 30% reduction in premature mortality from NCDs by 2030. And this report was published from that meeting, and it was at best very sober reading. At worst, it was very depressing reading, because what it showed was that most countries in the world, even high-income countries, but certainly almost all lower middle-income countries, were not even coming close towards achieving that Sustainable Development Goal target. And in fact, in this terrific article, which was published in The Lancet at that time, less than 20% of countries looked like, at that time, achieving their target by 2030. Kind of related to that is the fact that in thinking about what are the solutions, what are the things that countries could do to achieve those targets, the WHO recommends these so-called best buys, which I'm sure many of you are familiar with. And I think of the best buys as being like the what's to do. These are the things that countries could do to address behavioural, social risk factors and health issues related to NCDs in their countries. But the problem is they are only the what's, they're not the how. So having this information doesn't help a country fund the implementation. It doesn't help a country adapt these best buys to their context and setting. It doesn't help countries build local capacity, research capacity, policy and other kinds of capacity, health workforce capacity to address these targets. And in fact, with this paper that was published in BMJ Global Health in 2018, what they identified was that the majority of the best buy interventions didn't have any good evidence at all for effectiveness or implementation in low middle income countries, including those best buys related to very important areas like nutrition and diet and physical activity. So this is the challenge for us as implementers or implementation scientists. How can we generate evidence that your countries or other countries can use for effective implementation to improve their health outcomes? Because if we're not doing that, neglecting this, neglecting implementation science, it's costing lives, it's costing money, and it's impacting on our whole communities and the whole of society, whole of our economies, and we could be doing a much better job and doing a much better job at preventing much of the mortality and morbidity which is otherwise occurring because it's not being addressed effectively. I really like this quote from Louis Pasteur, a famous French biologist and scientist from almost 150 years ago. He said, to him who devotes his life to science, nothing can give more happiness than increasing the number of discoveries, but his cup of joy is full when the results of his studies find practical solutions. So I think that's important for all of us to reflect on, because I assume this is why most of you are so keen and motivated to attend this school, and why you are going to devote so much of your lives in the next 2 weeks and beyond to advancing your knowledge in the field of implementation science, so you will be able to apply the knowledge and the research findings from the work that you do to find practical solutions and applications in the context, the health services or the other organisations, or working with governments or policy organisations in your countries or regions. It is sobering to realise that the traditional kinds of outcomes research and clinical trials, which many of us have been involved with over the years, that it does take so many years for those research findings to be translated into policy and practice. And in fact, the majority of research findings, the majority of the thousands and thousands of research articles that are published every day in the international literature, most of them do not impact on policy or practice. So how can we improve that situation? We now understand what makes up that 17 years, why it takes so long to plan research, get funded, write articles, eventually get them published, and then to get them translated into policy or practice, if at all. This takes a long, long time. And there's other reasons, why this takes so long, and we can discuss some of these reasons at the first plenary. You can also discuss these from your own experience in your small groups as well. That often as researchers, we're not asking the right questions. And if we don't ask questions that are relevant to policy makers and practitioners, it's not surprising that when we go back to the policy makers and the practitioners with the results, it's not surprising that they don't make much difference. Often what we do, and this is particularly the case in prevention research, which come up against commercial organisations that often we're conflicting or there's tension with vested interests. The way we conduct research is very slow and non-responsive to the demands of policymakers. We can take 5 years to conduct a research study and get it published, while the policymakers and the politicians, they want a solution by tomorrow. So there's a bit of a mismatch between our respective worlds. We're also not very good at knowledge translation and policy and practice. So we'll talk some more about these issues and talk about some of the skills to address these during this 2-week program. In my naivety, I used to think that one of the problems with poor implementation was we didn't have policies, and that if only we developed an evidence-based policy, then it would get implemented. I think this is a very nice cartoon, courtesy of a colleague in South Africa, which I think illustrates that often the issue isn't not having the policy, it's either that the policies are not being implemented, or it's so very difficult to identify which are the appropriate evidence-based policies which could be implemented to really make a difference to a defined population or to a specific health issue. If I was giving this lecture live, I would stop at this slide. I would ask you, what is the most common kind of research dissemination or translation? And I'm sure that within 10 seconds, one of you in the audience, if you're not already saying it in your mind at the moment, would say the most common kind of research translation is bench to bookshelf, or from community project to a publication in a paper, in a journal, or presentation at a conference, or maybe even incorporating evidence and findings into guidelines, but it's not translation into policy and practice. So this program is really fundamentally about how we can do better than this, particularly in low middle income countries and resource constrained settings. But we can only do better by understanding how to do better, how we can reduce this evidence practice gap. How can we go from the evidence that we've got, the guidelines, the knowledge, and how can that be translated into real world policy and practice, whether that be health services, whether that be clinical interventions, whether it be public health or policy, or whether it's about communication with people in the community and the population to help them better self-manage a chronic condition. And this is often referred to as the no-do gap. Yeah. So how do we take what we know to do it better in policy and practice? So my proposition is, you know, if one of us is implementing, overseeing, or funding a health policy or a program, we should always have an implementation science or research agenda that's embedded with the implementation process. So the implementation and the implementation science and research should be entwined with the implementation. And that needs to be done because we often make assumptions about implementation which don't turn out to be true. So many interventions work in pilots or research conditions, but then when they're taken to the real world, they don't work. Why is that the case? Many different types of strategies can succeed, but it's often difficult to take all of those strategies to the real world and implement. Why is that the case? Policymakers are the ones, and program developers are usually determining the strategies for implementation, but then often they're not the ones actually doing the implementation. It might be people like you or I who are responsible for the implementation. So how well are we actually implementing what is specified in the policy or the strategy or the program? Strategies can often achieve their objectives, but often they don't always achieve their stated objectives, and sometimes they have unintended and unpredictable consequences, and sometimes people who should benefit don't benefit, or people who don't benefit, it can be a detrimental impact on those people. We often claim with our strategies and policies that they're going to benefit the poor and vulnerable people in the population. Evidence would suggest, and I'm sure this is probably the case with yourselves, that this is rarely the case. So implementation research is needed to achieve international health goals as well as national and local health goals. And we can only do that by becoming much better at reducing what I've called the no-do gap in real-world settings. So there's been a lot written about this in the last 4 or 5 years. 6 or 7 years ago, if you talked about implementation research or implementation science to many of our health science colleagues or health researchers or policy makers, it was often hard to agree on what was being talked about. I think that challenge is much less now. I think there's now a common understanding that implementation research can make a real difference to the new imperatives and opportunities in global health. We'll come back to this again and again. This is a paper that I wrote with some colleagues, mainly from WHO, after a workshop that we conducted in Russia about 18 months ago, where we talked a lot about the WHO best buys and the need to understand contextualization better. One size does not fit all. So just stating a best buy that a country needs to introduce a tobacco tax, a tobacco tax in one country is going to need to be implemented in a very different way, and the implementation process needs to be very different in one country compared to another. So one size does not fit all. And then I would just like to finish at that point and make the plea for you to just think about this challenge of implementation in your own countries and contexts, and also how this has really been affected in the last 9 months by the advent of COVID-19 and how that's really going to make the challenges of improving the prevention and control of chronic conditions like heart disease and diabetes and screening for cancer already more difficult than was already the case. And in the next lecture, 1B, I'll talk some more then about what is this field of implementation science. Thank you all so much. Thank you.